Good afternoon, everyone. My name is Brooke Bosma. I'm the Chief Development Officer at St. Paul's Foundation, and we're just beginning the webinar now. We're going to give it about 30 seconds to a minute for all the attendees to get on, and then we'll begin again. So if you can just be patient for another minute, we're about to get started. Thanks so much. Well, good afternoon, everyone, and welcome. This is a very special webinar brought to you today by the Providence Breast Centre. It's a privilege to be here in Vancouver, in British Columbia, on the unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh nations. We are grateful for their stewardship of these lands that we call home. My name is Brooke Bosma. I'm the Chief Development Officer here at St. Paul's Foundation. And it's really my privilege to be here today to MC and to host this session. For those who haven't met me, I'm sure I've met many of you on the call, or on the video conference, but I'm not just a staff member at the foundation. My family is quite connected to St. Paul's. I had 3 nieces born at St. Paul's. My mother is an ongoing patient in a number of clinics at St. Paul's, and my brother is actually one of the physicians at St. Paul's who works with some of the people that you'll be hearing from today at MSJ. My family and your families too know firsthand the truly exceptional care that is a culmination of skilled specialists, leading edge research, and a culture of innovation and collaboration. And when all of those things come together, care can be truly life-changing. That's why today we're very, very proud to celebrate the 10th anniversary of the Providence Breast Centre, to reflect on some of the center's incredible accomplishments, to look forward to the discoveries ahead, and to introduce you to some of our most hardworking and some of our most inspiring physicians. Let me begin though with a few housekeeping notes. This webinar is being recorded so that we can share it with those who aren't able to be here today. However, only the panelists and the presenters are visible on screen. You are not on camera, and everyone is muted. This afternoon's event features the opportunity to meet the founders of the Providence Breast Centre, presentations from 3 of our leading physicians, a short video, and a roundtable discussion with our panel. We'll close today with a question and answer period, and you can submit your questions at any time in the chat box. So at the bottom of your screen, there's a little box that says chat, or Q&A rather. If you click that, you can enter any questions you'd like for us to consider at the end. If you like a question that somebody's already asked, you can go on and give it a thumbs up. And then those questions will get higher into the queue for sure. Okay, we have so much to share today that we're going to start by introducing Dr. Rebecca Warburton. Dr. Warburton is a breast surgical oncologist, a general surgeon, and the current medical director of the Providence Breast Centre. Welcome, Dr. Warburton.
Great, well, thank you so much. Thank you to Brooke and the whole foundation team for setting up this event, and mostly thank you for all you attendees. We can't see you, but I've been told at the end we get to see everyone's face, so I look forward to that part. I'm just going to share my screen here and we'll start the first presentation. So I'm very pleased to be here with you all today to celebrate the 10 years. It's a little over 10 years, but we'll take it at 10-year anniversary from the Providence Breast Centre. Not exactly how we all wanted to celebrate this. Would have been nicer to maybe have a nice mingling wine and cheese event, but we are adapting, and that's part of what we do at the Providence Breast Centre is we learn to adapt and we grow and we change. So I'm happy to spend the next 45 minutes with you all talking about what we've accomplished and what we plan to do in the future. So I like this image as what we kind of envision our Providence Breast Centre. We started as a small seed, a little bit of money from the government, and we've grown into something that we're all really proud to be a part of. We've grown into something that we collaborate with multiple disciplines. We have grown into a big group of surgeons, radiologists, pathologists, anesthesiologists, all working together very closely to give the best care to our patients. As it was mentioned in 2009 in July, the breast center opened at Mount St. Joseph's Hospital, or started at Mount St. Joseph's Hospital as the Rapid Access Breast Diagnostic Unit. It was done through some seed funding through the government, and then ongoing support through Providence Healthcare has been instrumental, along with the St. Paul's Foundation, helping us grow into what we've become now. Many of you, if you're patients of our clinic, or many of us on the panel, will recognize the lady in the top right of this picture. That's our lovely Imelda Villeneuve. She's been with the clinic since it started, one of the nurse navigators, one of the pillars of our breast center. Through her perseverance and really driving this and her loving, caring approach to patient care, we've really been able to grow into what we are today. Over the years, we got, sorry, a bit too far. Over the years, we grew and we got bigger and we outgrew our space. So with the help of the foundation and very generous donors, we were able to renovate and expand our space. And we opened new in October of 2016 with our new renovated space that many of you may have been in. With that new space, we were able to grow our team, increase the number of surgeons, and most importantly, increase the number of patients that we could care for. Breast cancer patients, or patients that were suspicious for breast cancer, or patients who have breast diseases that aren't malignant, we care for all those patients at the breast center. And this increased space has really allowed us to grow into what we've become as a centralized regional center for breast cancer management and breast disease diagnosis and treatment. We've been able to grow into what we are, which is treating about 20% of the patients' the province's breast cancer patients, and operating on about 25% of the breast problems in the province. So we really are the provincial leader in the surgical management of breast disease. And the way we've really done that is focusing on these three pillars. And these are very important to our success and very important to how we want to grow and innovate. So focusing on teams. Our multidisciplinary team is how we approach every patient with a breast problem. The values, not only of the Providence Healthcare, which have strong values of patient-centered management and patient-centered care, but also providing valuable care to patients, valuable education materials, valuable surgical interventions, making sure that everything we do adds value to their care. And then reviewing that by looking at quality, always going back and looking at what we've done and making sure it's the right thing. And Dr. McKevitt will talk a little bit about that. And we really want to focus on providing quality care as well. One of the major, sorry, it's a little bit slow to advance the slides. One of the major ways that those three pillars are really represented is in our immediate breast reconstruction program, which Dr. Bova will talk a little bit about later. It really exemplifies the extraordinary care we give patients in the breast center. We have run the largest immediate breast reconstruction program in the country. Many patients coming through our breast clinic will result in a consultation to one of our plastic surgeons. Lucia was one of our patients who came to the breast center. Maybe she's on the call out there, I'm not sure. But she was featured in the Scotiabank Feast of Fortune fundraiser this year that St. Paul's Foundation had put on, supporting women's health. Much of that will come to the breast center at Mount St. Joseph's Hospital to help our breast reconstruction program and help people like Lucia go through this process with a little less uncertainty, a little more efficiency, and always providing the best level of care. So for the next 40 minutes or so, we're going to go through a few things. Dr. Estebova will talk about surgical innovation, and then Dr. Elaine McKevitt will talk about our surgical research, all focused on breast problems, and I'll run through the breast center, and then I'll at the end talk a little bit about how we want to focus on the patient experience going forward. That's our new area of interest. Is we can tell you all the statistics and numbers about breast cancer and all those things, but we really want to know how all this management and care impacts you, impacts the patient. How do they experience their survivorship through breast cancer? So that's our next focus. But before we get into that, we've got a couple of special guests, Dr. Irva Kusk and Dr. Nancy Van Laken. They were really at the forefront of the start of the breast center when that government offered up some seed funding to create a breast center. This was offered throughout the province, and Mount St. Joseph's Hospital and Providence Healthcare really monopolized on that opportunity and created what we all work in today. Dr. Kusk was the medical director when the breast center first started. She's also a breast surgical oncologist in the city, a very prominent member of our team. Dr. Van Laken was the head of the Department of Surgery at Providence Healthcare when the breast center was first developed, and they worked together quite closely to build what it has become today. Dr. Van Laken was Lucia's surgeon, who was featured in the Feast of Fortune campaign, and she's still working with us in the breast reconstruction program. So I'll leave it to Irva.
Good afternoon, everyone. I'm glad to be able to speak to you. My task has been in 2 minutes to say, why did we start the breast clinic? I'll try to keep it to 2 minutes. There's about 10 years of history to go through, but I'll see what I can do. If I miss something, so be it. Basically, the breast clinic, we started to meet a very well-defined need. It was very clear to us doing breast surgery that there was a significant delay in diagnosis. And we even heard of people and saw people that were 6 months before their cancer was diagnosed from a lump. When it was delved into as to why is this a problem, it really was a systems problem. Mount St. Joseph's is actually the only hospital in urban Vancouver that has a radiology department. All the breast radiology is off-site. They're grid clinics, but they're off-site. So if a patient came to a doctor's office saying, I have a problem, they would go to one radiology clinic, maybe another one, back to their family doctor, to a surgeon in a separate office. And it was clearly a very scattered, disjointed process, and it was getting worse throughout the province. So when the funding came from the government, who recognized that this was a problem, can we do this better? With Dr. Van Laken's support, the Department of Surgery support, radiologist, the pathologist, the whole team got together and said, yeah, we can make it better. We can at least make a small change. We can be leaders. We can do this. So based on breast clinics aren't new. Based on really the experience in Europe and some of the ones in the US, we sort of devised a plan. We had the funding from the government, but we had to actually do a diagnosis in 20 days. So that really put the pressure on, and we thought, yes, we can do this, but that's why the whole team had to participate. And we did have the radiology on site, donors bought a new machine, and we moved into what was the vacated intensive care unit, which isn't exactly an outpatient clinic, but you wouldn't believe what you could do with curtains, flowers, furniture, and it worked very well. So instead of the patient going all over the place trying to get a diagnosis, the system was set up such that when a referral came through to us, the clerk would book her in, go to radiology. She would then get triaged with the nurse. The whole process was seamless. Once you were in the system, everything you needed to have done was organized. You had nurses to talk to, navigators. They would put it through. Most patients have a benign problem. They saw a family doctor specialist at the end. The diagnosis was given to them. They usually went back to where they came from. But if there was a cancer, if there was a problem, they were triaged quickly to the surgeon. So the whole process became much better for the patient. Word got out there. And of course, when word gets out there that this is happening, then there is a sense of competition. And all of a sudden, the spin-off is that the rest of the providers thought, well, if they can do that, we can do that. And there was a lot of rejigging, and it probably was over a few years, but we noticed that all of a sudden, diagnosis was quicker everywhere. And that, of course, is a great thing for the patient. So we tried to fill a need. The clinic opened with great fanfare, I will say, because even the Minister of Health at the time came. So they were very supportive to the whole system being changed. And as Rebecca said, now that we've succeeded in that aspect and really don't need to focus on diagnosis. And our clinic was very small. We couldn't get any more, we couldn't do any more with the diagnosis thing. And really the needs were surgery, looking after the whole patient. And again, with donor funding, with a great deal of dedicated people involved, the new Providence Breast Centre opened up. So we started with the need of diagnosis. Now we're meeting a whole lot of other needs. And I think with everybody involved, it is really special. It is one of the best, the only breast clinic at this point around in Vancouver. Hopefully there will be more clinics. There are more happening here and there, but I think we're leaders, and a lot of our information gets passed down to others. It gets adopted, and I'm really proud to be part of it. And even though I'm theoretically retired, I like it so much. I'm still there working as a diagnostic physician. So I think the whole team, as Rebecca said, has made the big difference. It is a wonderful place to work, and I think it's a really great experience for the patients. And thank you to the whole team.
I'm very pleased to be asked to participate in the webinar regarding the celebration of the 10th anniversary of the Rapid Access Breast Clinic at Providence Healthcare. I recall more than 10 years ago when a number of dedicated individuals came together to design a program so that we could expedite diagnosis and treatment for women with breast disease and breast cancer. It was by the sheer determination and passion of the involved individuals that we were able to bring a multidisciplinary team together to provide expedited care for our patients. This included initially predominantly diagnostics. We've now been able to extrapolate that into shorter wait times for surgery. And in the process of increasing our volumes, we've also been able to advance our surgical techniques, incorporate research into the program, and involve more individuals in the overall care of our patients. We are hopeful to continue to expand what the work that our clinic does, continue to look at our outcomes, evaluate, and improve our treatment of all of our patients. And we've always been extremely grateful for the support that we've received from the hospital, from the surgical program, and most importantly from our donors who have been able to allow us to perform many of our advanced investigations with their generous support. So congratulations to everyone involved, and we look forward to another 10 years of ongoing development. Thank you.
Well, thank you so much, Dr. Koost and Dr. Van Laken. Dr. Koost, I think you got in under the two minutes. I do hope that we have some questions for you at the end. It's such an incredible story to hear about how this all came about and how truly the whole province has benefited from it. We were privileged to have Dr. Van Laken make that video for us, as she's actually in surgery, I believe, right now. So with that as a backdrop and as a history, I want to encourage you to think about questions to ask. Go down to that Q&A box and type them in. And now we're going to hear from Dr. Elaine McKivitt. Dr. McKivitt is both a breast and general surgeon at Providence Healthcare. She is also a teacher and a breast cancer researcher at the Providence Breast Centre. Dr. McKivitt.
Thank you. I wanted to thank the Foundation for organizing this event and for the opportunity to talk about the research we're doing at the Providence Breast Centre. I'll just share my screen here. I think we've got this up. Here we go. So I've been asked to talk about the research we're doing at the Providence Breast Centre and how it's helping to de-escalate surgery and reduce complications for patients. A theme to this presentation is going to be the teams that we work with in pathology and radiology for diagnosis, and with oncology and plastic surgery for treatment. As well, we couldn't do it without the team in the clinic, and that includes our research team, many of whom are pictured here. The Rapid Access Clinic, as you heard, opened at Mount St. Joseph's in 2009, and this slide diagrams what Dr. Koost was talking about how the development of our program changed access to breast cancer diagnosis in the city. On the left-hand side, I've diagrammed the 10-step process patients used to go through with their family physician, where they were then referred on to the surgeon once they were diagnosed with breast cancer. On the right-hand side, it diagrams what happened with our program, where a patient would be referred to the program by their family physician, and the program would then coordinate the rest of their care. With this, there were fewer handovers, so fewer opportunities for things to be missed. Oh, hello?
There we go.
With fewer opportunities.
Your screen.
Oh, has it come up?
We've got it now. Yes. Thank you, Dr. McGivitt. We were just missing it. It looks great. We've got it now.
Shall I start again? Oh, you've got it. Okay. So
I think we're good. Thank you.
Okay. On the left-hand side, we have the 10-step process patients were going through compared to the new process with the Rapid Access Breast Clinic. This resulted in fewer handovers and fewer missed opportunities for care. While I've diagrammed the traditional approach in a straight line, patients described it as much more like this. The first study we did through the Providence Breast Centre really looked at these processes, and it came about in January of 2011 at our Feast of Fortune fundraiser, where our then directors, Dr. Nancy Van Laken and Cheryl Bishop, told us that the government had asked us to provide evidence that this approach was in fact better, and that we needed to provide that within the week to continue our funding. Right then and there, we designed a study to look at how long it took patients to go through the two different pathways of care. And we then had those results within the week and kept our funding. These are the results we found, showing that it took an average of 86 days to go through that diagnostic process through the usual approach, compared to 33 days through our clinic. And this was true for patients with cancer or who had benign disease. We then went on to break down the different times, and we showed that by coordinating and all of the different steps in care resulted in the big impact in wait times. And we then addressed the question that people brought up of whether or not our public healthcare system could afford such care. We showed that this care, in fact, was cost effective and saved the system money by avoiding duplication of services. Around the time the clinic was opened, it was recognized there was a higher than expected surgical biopsy rate for diagnosis of breast cancer. And through collaborations and educational initiatives in radiology, pathology, surgery, and collaborations through the Cancer Agency, including the data I've just shown you, we were able to decrease the surgical biopsy rate for diagnosis of breast cancer from 41% in 2006 down to 9% in 2016. As well, we've looked at wait times to treatment for care, as Dr. Van Laken was alluding to. This is an example from a study we did looking at access to breast reconstruction at Mount St. Joseph's, where we changed the way we schedule surgeons, deliberately scheduling both the general surgeon and plastic surgeon in their operating room on the same day. And this has allowed us to increase the number of reconstructions we can do from 75 to 139 per year. Most importantly, this decreased wait times to surgery from 70 down to 52 days. So that means the average patient was able to access breast cancer surgery 3 weeks quicker with these innovations. As well as looking at the processes of care, we started looking at how we should be applying results coming from other international institutions to the way that we care for our patients. With research, we're looking at the question of how do we make treatment better for our next patient. And to look at this, we have followed best practices and developed a database of all the surgeries we've done. And over 10 years, that's got about 12,000 procedures logged in our database. We use this for our quality assurance, and we also use this to model how any changes in care might affect patients here in Vancouver if we were to make them. An example of this is a study we did looking at patients who have something called atypical ductal hyperplasia on a core biopsy, or ADH for short. And this is a circumstance where we would usually take that area out with surgery to see if there are any cancer cells nearby. What we did is we looked at all of our patients who have this particular diagnosis, and we were able to look at all of their circumstances and model them out. And we came up with a group of patients that we felt would be low risk for needing surgery. And this is a group of patients we think have about a 2% chance of finding cancer. So if a patient falls into this group, we now offer them the opportunity to have follow-up mammograms instead of going straight to surgery. And just a few weeks ago, I had a patient who fell into this category, and we were able to review her circumstances with our radiologist and pathologist at rounds, offer her those two choices of how to approach this. And during COVID, she was very pleased that she could have a 6-month follow-up mammogram and didn't need to come to the hospital and the operating room. So with our database, we can look at how all of these changes affect our patients, and you can see that we've decreased the number of surgeries we're doing for these so-called high-risk lesions from 2017 to 2019. This is freeing up operating time to get our patients with breast cancer into the operating rooms, and we think this is allowing us to be very responsible with our resources and get the right people to the OR at the right times. As well, we've taken a similar approach to looking at how we treat breast cancer and how we do surgery for breast cancer. And a number of studies have come out from other institutions that are questioning how we're doing surgery and wondering if we're over-treating patients with regards to lymph node surgery for breast cancer. Patients are always concerned about the number of lymph nodes that need to be removed because there is a possibility of swelling of the arm or lymphedema. And there are some recommendations saying that we don't need to be as aggressive. But with these recommendations, surgeons, oncologists, and patients have been concerned that were we to follow them, we might be under-treating people. And what we've done is we've taken our database of patients, looked at how patients do in our institution, and including collaborations, looking at outcomes with BC Cancer, we're able to say that our patients have outcomes similar to other centers in the world, that our patients could expect similar outcomes, and we now have circumstances where we don't need to be as aggressive with surgery. And having this database and this ability to look at that has really increased our confidence in making these changes here in Vancouver. We've been very fortunate to have multiple research collaborations. We work with surgeons throughout the province and across the country on different projects. We've had tissue banking collaborations, storing tissue for future studies with BC Cancer. We've worked with UBC Physio and UBC Epidemiology. And we've been very fortunate to have hardworking and bright UBC medical students, fellows and residents who've worked with us on various projects. Most recently, with some assistance through the foundation funding, we've been able to hire students through the UBC Science Co-op program who've helped us as research assistants. All of this has led us to an increasing amount of academic activity through the breast center. And on this slide, I'm showing some of the activity we've had for the past 10 years, with the blue bars representing local presentations, the orange bars, national and international presentations, are the gray bars representing peer-reviewed publications, and the yellow bars are our most recently submitted projects. So in summary, over the past 20 years, we have shifted from surgical biopsy for breast cancer to image-guided biopsy, and clinics such as the Rapid Access Clinic have facilitated this kind of care. We have evolved from taking guidance from research done elsewhere to incorporating our own data when looking at making changes to patient care. And this has led to multidisciplinary assessment and tailored care for breast cancer here in Vancouver. As I conclude my presentation, I want to tell you about the comments a patient of mine made on Friday when I saw her in clinic to go over the results following her surgery. She told me about how worried she was when she found out she had breast cancer and how concerned she was when she was told that she would need to have surgery. She told me about the care and confidence that she received from each member of the team and how it had helped her get through this. Specifically, she commented on the staff that called her with appointments, the nurses in the clinic, in radiology and in the operating room, the porters that helped her move through the hospital, as well as the doctors who saw her. She commented to me about how she saw all of us working together to take out that cancer, and she wanted me to pass on her thanks to each and every member of the team. On thinking about these comments, I also think we need to recognize all of the contributions from our research team that have really helped us to build this clinic as well. Thank you.
Thank you so much, Dr. McKivitt. That is a whirlwind of accomplishment over the last decade. And it's exciting to see what has happened over the past decade and to dream about what could be as we continue to work together as a team with research, surgery, imaging, radiology, acute care, all of it in order to move forward in this for the Providence Breast Centre. Our next guest is Dr. Esther Beauville. Dr. Beauville is a plastic reconstructive surgeon at the Providence Breast Centre, and she has special training in using microsurgical techniques to reconstruct the breast using the body's own tissue and to avoid the sacrifice of major muscles of the body. Happy to turn it over to you, Dr. Beauville.
Thanks. Thank you for that, Brooke, and to my fabulous colleagues who I look forward to working with every Tuesday in our swing rooms at Mount St. Joe, and good evening to all of you, and thank you to the Foundation. And it's my pleasure tonight to talk about some of the innovations currently or imminently in use at Providence. As you have all been hearing, we have an extremely successful breast cancer centre based out of the breast clinic in Mount St. Joseph, but as the plastic surgeon, I am very fortunate to be part of the immediate reconstruction program, which, although forms but a tiny part of the breast centre service, has in itself grown to be one of the most, if not the prolific in Canada, which for a relatively small group of dedicated people is quite the little blue engine, to be honest. But to keep us up there, we have had to certainly evolve and adapt to changing times, becoming ever more efficient, not least to increase access to as many patients who would like and seek reconstruction as possible, whilst maintaining the optimal and excellent outcomes for all of those patients. And part of this evolution relies on state-of-the-art techniques and equipment and knowledge, and that's partly where the Foundation comes in this context. Just see how we can, there we go. So I plan to briefly outline what exactly does immediate reconstruction kind of look like, but then mostly to elaborate a little on 3 exciting innovations that help Providence stay at the world-class level. So while a total mastectomy is absolutely the right choice for some women, any form of breast cancer surgery is likely to leave its mark, not only on the physical body, but also on the psychological. There are psychological effects that are inextricably linked to the physical scarring. And we do know from the literature over the past 20 years that reconstruction in those women who choose it does lead to significant advantages for those women, including reduced clinical depression, a restoration of the whole self. There's no need to wear a prosthesis. And those things help them overall to be returned to their normal psychosocial environment. To be honest, aside from all those things, the most basic underlying desire of most women that want reconstruction is that they just want to get back to a normal life. The general surgeons and the oncological management are the lifesavers, but it's the restoration to that normality that I enjoy as the immediate reconstruction and the delayed reconstruction for that matter. And in Canada, about 1 in 5 women undergo immediate reconstructions currently, although at Mount St. Joe, we are delighted to be a much higher rate than that, which reflects our work towards greater access to reconstruction. And currently, depending on their suitability, women have the choice of reconstruction in 1 of 2 significantly different ways. One with an implant, and then the other, as Brooke alluded to, with tissue moved from elsewhere in the body, which is predominantly abdomen, usually the tummy. Now, whichever procedure she chooses, the last thing a cancer survivor needs is the fear that something will go wrong with her newly reconstructed breast. And one of the risks that the tissue is that tissue that's left behind after the mastectomy, or even indeed the tissue that I'm bringing up from the abdomen, won't have enough blood flow in its new location. And if this happens, some or all of the recreated breast might be lost. So imagine the ordeal of and I'm sure many of you can, the ordeal of a cancer diagnosis, the mastectomy, and then reconstructive surgery after all of that for a woman to face losing her breast a second time. And this slide is meant to convey the importance of that team, that handover from the preoperative care, the diagnostics, the radiology, through the breast clinic, then the surgical oncologist who does her mastectomy. And this first innovation actually is about the preoperative diagnostics that can help me with the microsurgical procedures. But the 3 that I'm going to talk about are the CT angiogram, which is the preoperative imaging that I was about to talk about, the intraoperative perfusion imaging, which is something we use on the table in the OR, which helps the perfusion for us to assess the perfusion of the tissue, as I was mentioning. And then finally, but most recently and very excitingly, is the on-table radiography, the Trident machine, which helps us delineate whether the cancer is truly gone and lets us advance on with either just simple closure with the minimal amount of tissue needed to be gone, or indeed, from my perspective, that it's safe to proceed with a reconstruction. So firstly, the CT angiogram. Now this is these are pictures of somebody as if they've been cut in half, and this is where we can see with a CT angio, they injected with a dye, and you can just see the little blood vessel here, And this one in here is right through the muscle. Now, I don't want to use that blood vessel. I want to use this one. By using this one, I can avoid damaging the muscle of the patient, which helps their recovery and shortens their time during the surgery. And so that is of significant benefit in many ways to that surgery. Hang on. And by assessing the donor tissue in this way before I even start the flap, so this happens a few weeks prior to the surgery, I can reduce the length of the operation, the length of the patient's stay, and the risk of complication. And this is actually performed here at St. Paul's by our radiology team, and it's the only place that will do this in the Lower Mainland. And so even if I'm doing the surgery elsewhere, for example at VGH or UBC, it is the St. Paul's team that have led the way in the Lower Mainland to this innovation. And so we're very proud of that. The second innovation, the SPY portable handheld imaging. Let me put that in context. So the number one worry from my perspective after a mastectomy reconstruction is the survival of that skin that we have fought so carefully to preserve. It's very frail right after that surgery, and if any doesn't survive, that can increase the healing and recovery time for the patient, which of course we want to avoid at all, but especially if she needs chemo or radiation therapy. And with so much at stake for these vulnerable patients, we really want to do everything possible to assure the best outcome. And a key part of that commitment is to stay with the rapidly evolving surgical tools and equipment. And one of our most recent acquisitions, thanks to our generous support of donors, is the SPY portable handheld imaging. And this is this rather fancy machine here on the left. And on the right is here, it is in use, all beautifully prepped and draped, as you can see. And it's really like having, when I explained this to a patient, she said, is that like having, X-ray vision? And it was actually quite a good analogy, because in the days before this technology was available, we would use our experience and clinical judgment, as fabulous as that is, to place and secure the new breast tissue. But although I'm getting older and older and getting more and more experience, the problem with this approach is that it is impossible to see all the tiny but important blood vessels and to really know and predict how well the blood is circulating. And we often don't know until a few days later after the surgery if that skin's going to survive. But with the SPY, a dye is injected into the patient, and then this magic wand is turned on, and a special light causes that dye to glow bright green, illuminating that blood supply in the tissue right down to the microvascular level. And so with the blood flow so obvious and clear on table, that's where the X-ray vision bit comes in, because now I know where that skin is likely to survive or not. I can do something about it on the spot before that post-operative visit. And we have found that the instant feedback we're getting on the mastectomy quality has reduced our mastectomy skin problems. It's led to improved healing time and minimizes the delay to those life-saving treatments of radiation and chemotherapy. And this is just the example of what we're seeing on the screen in the operating room. So this dark shadow is the skin that would not survive, although I might not necessarily see it at the time. And this is just a color map, a little bit like a weather map, with the numbers on telling me where I really ought to do something about that skin if I can, which may require a change in the reconstructive technique, which to know that on the table is extremely valuable. So another fabulous new tool, again, this is the most recent and also funded by a very, very generous donor, is a specimen radiography machine. Now this is a little more of a general surgery approach, but it's even so, I have found that has improved the reconstructive access to exciting new techniques such as oncoplastic reconstruction, where we allow to optimize the amount of breast tissue that we can keep and reshape it on the table, again, trying to reduce the amount of overly aggressive surgery if possible. So this machine allows us to examine the biopsy tissue samples, while we're still in the OR. And now within moments, we can determine if there are clear margins, and we can decide on the spot if we can go ahead with reconstruction or if that patient needs further excisions or care first. And before we had this machine, we didn't know until sometimes 2 or 3 weeks later, when the pathology came back, whether that would be the case. that would be extreme. But even when we had the ability to send the tissue off on the same day, there would be more time on the table. We would have to send it off to a different room. It would be walked down the corridor. The radiologist would have to have a look at it. The general surgeon would have to have a look at it, with all this long delay. And now it's like putting it in the microwave. I've watched them do it. It's quite incredible. They put it in the microwave, bing, it goes up on the screen, and then they can go, no, it's all clear, off you go, Beauville, and it just saves all that time, which again, if we can get more patients through safely and successfully, is only going to increase access, which is really great. And here it is in use in the OR. You'll see Dr. McKevitt looking beautifully into the camera here with a light shining on her head like a halo. And there I am on the right. And the big team, I love this slide because it just shows the team that's involved. So these tools that are helping us make crucial, time-sensitive decisions while we're still in the operating room. And there it is. There's the Trident, hard at work, the microwave, as I call it. So let me share some patient stories with you. We'll call this patient Donna. She was actually a delayed reconstruction. She came to me from the interior. We take patients from all, there's no geographical limitation. And she came because she hadn't had access closer to home. And she wanted, for the life of her, to just get back into the abreast in a boat, dragon boat racing boat. And she felt that the traditional way, she wasn't suitable for an implant, but the traditional way to recreate a breast from the tummy was to take that muscle. And she was frightened that that would compromise her ability to do her dragon boat racing. So she waited 2 years, sadly, for me to turn up in town and be able to do a microvascular procedure for her. So she had her CT angiogram and she proceeded with a DIEP. And this was her with her World Championship medal around her neck, proud as punch. So I was equally proud of her because she actually was my very first DIEP patient. This lady, we'll call her Anna, equally fabulous. Presented, she had 3 young kids, was a very type A personality, an accountant, high stress job. One of those, oh, I'll just get my mammogram, and boom, a month later needed bilateral mastectomies. And here she is, she decided on the face of her positive outcome after surgery and reconstruction that she was going to give it all up. It made her life in perspective, and she decided to become a CrossFit instructor. So again, she doesn't need to be Angelina from reconstruction. She just needs to be able to wear, a tank top and not draw attention to herself. She just wanted what she called a normal, positive life. And she was definitely an example of return to function and form. And finally, this lovely lady I remember well, because sadly for her, she doesn't mind me sharing this, she was newly single at the same year, just before she was diagnosed. And so she wanted to get back out there and to be able to go out and date and just be normal. It was exactly her words again. And here she is, just shortly after her immediate reconstruction, again, able to wear a tank top. You can just tell very closely, if you look really closely, that she's had surgery on one of her sides, but completely back to a normal and positive life. And these patients are so inspiring, and have been very kind to let me share their stories with you. So I wanted to get across that these innovations have been really, truly life-changing for such patients. They improve patient care outcomes and experience overall. They improve our ability to work as a team. And that includes you, our donors and potential donors. And I wanted to thank you and the foundation for supporting our innovations in healthcare at the PBC. Thanks again.
Thank you so much, Dr. Beauville. It is truly exciting to see these different innovations at work and how things have changed over the years, and the hope that there is there now. And I just wanted to quickly give a shout out to all our panelists. Thank you for being here today. And now it's time for our attendees to ask questions and get some answers. So I'll do my best at moderating here, and we'll open up a few of these questions and see where we go with it. So the first question here is the new digital mammography machine up and running in the breast center yet? Who wants to take that one?
I can take that one. Yes, we have expanded our digital imaging in our radiology department. There is capacity to do more. We still do screening mammography. I don't think we have any of our radiologists with us today, but they are looking at ways to increase the services for our patients. And we definitely have our new machine up and running, doubling the capacity for women to get their diagnosis at Mount St. Joseph's.
Okay, great. That's great to hear. We're so proud at the foundation to have been able to assist in so many of the ways. And I did want to recognize, you know, we've been talking about the history of the Providence Breast Centre. We at St. Paul's have been a part of it for the last 3 years. Of course, our partners Tapestry, who are now part of us, were there at the beginning. And so we're thankful for all the work that Tapestry Foundation put into this, and I saw that picture of opening the breast center and was happy to remember that I got to be a part of that event. It was just as we were joining and merging the foundations. Dr. Warburton, I wanted to go back to you with one more sort of off the cuff question, which was, you know, we've heard about some of the exciting talk about the future of patient care at the Providence Breast Centre, and as the medical director of the center, would you tell us what does the future look like to you?
Right, so we definitely, I have a few slides. Would that be okay if I just show you a couple of the innovations that we're interested in potentially looking at for the future? A little bit of interesting work. So we'll just move along. So we've talked a little bit about how the breast center is really focused on changing this into a more straight line. And we've done that by focusing on our people and collaborations. But where we look to go forward is patient experience. And that's our next area that we really want to focus on, is we can tell you all the statistics and all the numbers and what it'll mean from a cancer standpoint or a complication or a surgical standpoint. But we really want to know the next phase of our research interests are looking at patient-reported outcomes. How does the patient experience this 1 year from diagnosis, 5 years from diagnosis, and see if we can tailor our treatments a little bit to get great cancer outcomes, great surgical outcomes, but also do it in a way that supports the patient's needs, similar to what Dr. Bovo talked about in breast reconstruction. Dr. McKevitt talked about our research assistants. So we have 2 research assistants within the breast clinic. We have 1 trial accruing right now called the Ruby trial. That's looking at women 40 years and younger. We would love to increase our capacity for clinical trials and surgery. There's lots of interesting and innovative trials going on. And right now our patients in Vancouver miss out on a lot of that. So to get them the opportunities to participate in clinical trials would be a great benefit for the breast center, but also for our patients. And then this reflects patient-reported outcomes. If you're a patient of our breast center, you're going to see this. Where are you happy? Are you sad? Where are you on the spectrum? So we're going to be really getting the feedback from the patient to find out how they're coping with treatments. The first one of our projects is we're going to start looking at the patient experience with a virtual consultation. COVID's changed everything about how we manage breast cancer and how we work. We can give you all the statistics and numbers on the left, but now we want to see how did patients feel about it? What did they think about a Zoom consult? Did they like the fact that they could have every friend and family on the consult if they wanted, or did they really miss that one-on-one opportunity to see you in person? So that's to come. Then there's all the other more innovative surgical interventions. Many of you who might have gone through the breast center might have had a wire localization procedure for non-palpable lesions, so a cancer that we can't feel. It's a bit old-fashioned, does a great job, works well, but there's new ways to do that. One of the ways to do this is called a radar tag or a Savvy Scout tag. They put this tiny little seed into your breast, and it can be done at any time before the surgery, and then we're able to find that little seed and get it out with this probe. Intraoperative breast imaging is something that Dr. Bovo talked about, our Trident machine, which is the picture there in the middle left. There's another machine that would be fantastic, and it's called a margin probe. Not only do we get a picture, but I can put this probe on the specimen and it'll give me my margin depth. And that would change everything about how we manage surgery. And then the robotic breast surgery. It sounds a little bit crazy, but that's where this world is going. And Toronto just did their first one in February. That's one of my mentors, Dr. Sill, with her robot doing a nipple-sparing mastectomy with breast reconstruction. That's on clinical trial. So a combination of clinical trials and using some of these surgical interventions, I really think we could advance the care at the breast center.
Wow. So we've accomplished a lot, and we have a long way to go. We have, it sounds like there's more out there for us to continue to innovate on and do. Okay, so you know, one of the questions here on the chat bar is, for each of you as physicians, you know, maybe take a minute. What are you each most excited about in your different fields of expertise for the Providence Breast Centre? Why don't we start with you, Rebecca?
Sure. As the role of the medical director, I think some of the streamlining care, advancing our care, expanding our scope of patients that we can care for, getting more subspecialized programs involved within the breast center. That's really my focus now. Really getting that patient feedback on what these treatments mean for them and how they go into survivorship with those. The surgical tools and the robots, those are all cool, and that's very interesting, obviously. But some of those systems things is what my focus will be on in the next little while.
Dr. Beauville?
So, Brooke, your brother is part of what I'm thinking is one of the most exciting things at the moment. COVID, ironically, has pushed us along this road. But traditionally, patients have all, after mastectomy and reconstruction, needed to stay at least a night in hospital. And something that we were thinking about for a while, but never quite were confident enough to do it, was to try regional anesthetics, whereby the whole chest area was blocked. It hasn't absolved us of the need to give a general anesthetic, but the pain relief that has provided per patients has allowed us to send them home the same day. And because of COVID, we were very much thought that that would be a good time to pilot that, because we wanted patients in and out of the hospital and away from that healthcare exposure as soon as possible. And patients equally were keen to try that. And we have found that that has been extremely successful in getting out of the hospital the same day with good pain care, so that and that overall, I suspect, we are auditing that, but I suspect that that will make their experience much less of an ordeal than it currently is. And to my mind, that is, you know, we're all trying to find positivity out of the COVID pandemic, and that is a very significant one for our patients.
Thank you. Dr. McKibbett. Oh, Elaine, you're on mute.
Here we go.
There you go.
I think we could, there we go. I think to add to what Dr. Warp and Dr. Beauville said, I mean, some of the recent innovations we've seen with the patients having regional anesthetics, I've heard very, very positive things from my patients. I have been fortunate to work at the breast center since we opened, and just seeing the changes in care, getting patients through more quickly, expanding what we can do has been exciting, and I'd love to see that continue. I was asked to talk today about our research, and one of the things I thought of as I was looking at and putting this together, one of my patients last week said to me, "Well, you sound very confident in what you're saying. And because of that, I'm going to follow your advice." And I really thought that was because of what we've been able to do, understanding how our patients are doing, understanding that, you know, our results are similar to elsewhere in the world, and being able to say to patients, you know, we've looked at this is what we're seeing, this is what we would expect for you, were you to follow these steps that we're recommending. And I think that's been really exciting, and I'd like to see that continue, and I'd like to see us continue to integrate into the Cancer Agency and the region, and really expand what's being offered to patients beyond the city of Vancouver and through the province.
Yeah, exciting. Dr. Kusk?
Sorry, I was muted. I think some of the things that the cancer is being dealt with, but some of the things that we do not have in this city is we don't have follow-up clinics for high-risk patients. Those are expensive to do, but these people really get lost in the woodwork. So there's a whole group of people that don't need a surgeon, but that really do need follow-up. I know the other clinics do it, and I know Rebecca and I have talked about this, but following the high-risk patients, following some of the cancer patients for a while that need to be seen, we don't really have the capacity to do that now, but I think that is really helpful for the patients.
Interesting. Yeah. So more work to do for sure in the future. On to this next question here. We have just a few minutes left, about 3 or 4 minutes. Thank you for taking the time to share your work today. I know you are all very busy. Your center helped my mom 2 years ago. How do we help you? So that's the question, is how can people, help the Providence Breast Centre? And Rebecca, maybe I'll ask you that question.
We're very proud of what we do, and it's always nice to get those comments from patients who are also very pleased with how the process has gone for them. It's a terrible time for a woman to be diagnosed with breast cancer, and then to be supported by the breast center, and then for that to be valued. I think that's what keeps us all going to work every day, is those moments with patients that have really been touched by your care. However, that goes so far, and then we do need to advance our care with innovation and research support. Those are things that the hospital and the institutions aren't able to support us as much as we like. We've had a lot of donor support in the past supporting our research co-op program, which we would like to continue, and then all the surgical equipment and surgical innovation that we've talked about in the past is definitely something that will be useful for us to progress our programs.
Thanks for that. And I encourage anybody on the call to reach out to the email where the invite was, and reach back to the foundation. We've been honored to provide a connection between grateful patients and the clinic for many years, and to facilitate gifts and the purchase of much of the equipment. So if you are interested in helping, please reach out to us, and we'll connect you. I'm going to go a little out of order here. I think there's a question here that's really interesting, which is, if I'm a patient in a remote or rural part of BC, how can I benefit from the Providence Breast Centre? Who wants to take that one?
Do you want me to
Sure.
take that one?
Okay,
one of my other hats, I'm the lead for the breast tumor group, surgical breast tumor group for BC Cancer. And so I will also be looking at that question for people in other parts of the province. We work with people in other parts of the province, and as surgeons, we're sharing our experience. We're sharing our research. We know some of the research numbers. I showed you that where our initial studies went to the government 10 years ago, that has been used to facilitate changes in care, changes in process throughout the province. For some patients, if they are looking for a procedure that is provided in Vancouver, but perhaps not in a remote location, that they may come to Vancouver or have a remote consultant come to Vancouver and have care in Vancouver, if that's where the best care will be for them. We also work with surgeons in all the communities. They will often phone us, they will ask us questions, and we will try to provide support so that patients can stay closer to home and still have the benefit of some of what we've learned in Vancouver. We're involved in education, we're speaking with surgeons, and there's going to be some initiatives hopefully coming up on a provincial level where there's going to be an increase in collaboration, communication, and more multidisciplinary care that would be available in the remote community, so patients can stay closer to home, but their surgeons can work with people in Vancouver, and that can change some of what is available to them in their locations.
Amazing. Well, we're just at time here, and so I wanted to say thank you, and to extend our deep appreciation to Drs. Warburton, Coos, Van Laken, McKivitt, and Beauville for sharing your experience and your insight, and also your future vision with us. It's safe to say that everybody on this call knows somebody, has been impacted by somebody who's been diagnosed with breast cancer. And it's empowering to know that the Providence Breast Centre is available for patients, as you just described, Elaine, all across BC. And that, you know, they have access to passionate, patient-focused, and innovative caregivers with you know, such a deep well of expertise. I want to thank everybody who joined the webinar today. You have great questions. Unfortunately, we couldn't get to all of them. We are happy to respond to them, you know, offline, one-on-one, and email those. So please feel free to, you know, if you'd like to email us, contact us, and we will get back to you with those responses for sure. With the tenacity and the talent of the people that you've met today, and with the support of incredible donors, we're going to continue to lead the charge to improve the lives of British Columbians with equal parts compassion and with equal parts leading edge innovation. We truly couldn't do this work without you clinicians, so thank you, but also without our donors. So any donors on the call, thank you so much for your support. And thank you for being with us on this journey over the last 10 years. Enjoy your afternoon or your evening, and thank you again. Please contact us with any more questions. Good evening.